Thanks, Dr. Goldenberg, for joining me today. I am Allison Weens with the Underserved Populations Program, and I work as an education and liaison nurse to help folks here understand what health equity is, as well as aim to bridge the gaps that exist in our system with the Underserved Populations Program at my side. Today, the purpose of this interview is to discuss what your experience is with equity, inequities, disparities, and how that affects your practice as a medical oncologist. We are aiming to get Cancer Here Manitoba to engage with us around our equity initiatives. It's something that's certainly important to folks at Cancer Care. There's lots of clinicians working hard to understand equity and equity-related issues. And you are certainly one of the folks who sees this as something really important and valuable, and a critical part of practicing and supporting patients. So why don't we just dive right in? You, of course, are a medical oncologist. You've been here now for multiple years.
Three
years.
Feels like 30.
30 years. And you have been providing really excellent care to clients with cancer, and really, when needing to, looking outside the box of what it means to provide equitable care when people are facing significant disparity. So tell me a bit about your experience in your practice with inequities when you are working with patients.
Thank you. Thank you for asking me. It's a privilege and it's an honor for you to actually single me out and ask me, and because it is clear that without all the both structural detriments and barriers, and without the team of support around the patients I take part in caring for, that there's no way sort of any sort of positive outcome, whichever way you look at it, would actually be achieved. I'm from Winnipeg, speak English as my first language, grew up in a professional family, and grew up with relative privilege. But it has also been imprinted upon me and ingrained upon me that privilege is tenuous, and that everyone, all our neighbors, all our community members deserve access to the same sort of privilege that I've been gifted with growing up. Medical school here was, and it's improved as far as our communication, access to things outside of the conventionals, like Western male medical model that our entire evidence is built on. It's improved. However, it was clear from the beginning that the majority of our population aren't afforded the access and the quality of comprehensive care that the privileged minority have been. And the question is why and how, and those are huge questions. My first sort of marked experience was between the first and second year of medical school. I had the opportunity to work with TB control. There was a outbreak in cluster First Nations communities in Island Lake, and the big message from a large, academic center with a well-known TB researcher was just make sure that everybody has great ventilation and good hand hygiene. I was able to spend 2 weeks on reserve, and the majority of the homes did not have running water. They had a large sort of cistern on their front deck, and there's just this massive disconnect from what we know and experience with our own eyes, and from what many of our patients, clients, no matter what, our neighbors, are the people that we're caring for, are actually personally experiencing on a daily basis. As a medical oncologist, all that ends up being quite clear and crystallized in the clinic space, because lots of our decisions are made based on people's social support. Is this person reliable enough to be able to report toxicities of the things that we're giving them?
Mm-hmm.
Do they have, and this is a predominant part of my initial interview when I meet a patient, do they have both the physical support? Do they actually have a house?
Mm-hmm.
Obviously, we shared a patient that we cared for who had lost access to housing. I've had patients that did not have a kitchen.
Mm-hmm.
These, more than anything, more than like the 15% survival benefit one can offer with 6 months of some chemotherapy, can determine people's wellness. And so just to get back to, as a medical oncologist, there's a huge world of history, of contemporary pressures, of structural limitations that have actually led to this initial meeting in my clinic space, and that cannot be ignored because it's in front of us.
Mm-hmm.
Without a doubt, whether one has lived their whole life in a remote sort of northern mining town or in a southern reserve, or is previously living independently and has disabilities from whatever. These things are put in our face in the clinic setting because they're all part of how we can best care for a patient and their family. And so, as I was saying to you earlier, Alison, I do think that in that clinic room,
Mm-hmm.
where the door is closed, that and once they've seen a medical oncologist, once they've had that access,
Mm-hmm.
the cancer itself is an equalizer. Cancer care works very hard in bringing those patients into the door.
Mm-hmm.
There's been a huge amount of work over the last 10 years of shortening that time from suspicion and diagnosis to actually meeting one of us.
Yes.
And so that opportunity that people have across the room from me and my peers is of great import. However, it would be incorrect, disingenuous, it would be a matter of hubris to say that's the most important and defining step in getting them to have the appropriate care.
Right, that's a really good point. And really what I'm taking away from that is the importance of looking outside of the cancer alone and the picture of that cancer alone and what that diagnosis is, because the factors that that person lives with are really going to be a huge part of how they move through that cancer continuum, and whether or not they get to reach the outcome of the 15% improved survival that you'd hope for if you are able to offer them that treatment. And there's so many factors that would depend on them being able to actually undertake treatment. And this is true for every individual, not just those we might see and believe to be underserved. And that might be, a really good point too, that not everyone that we meet, we will understand what factors they live with.
Right.
And it's so important, as you had said, to understand the factors that impact our clients, so that we can really support them appropriately and in an equitable way.
Yeah, I mean, there's no way that as an individual physician or as a connected primary nurse that we as 2 or 3 people can actually adequately support someone who is not only individually complex and multidimensional, but comes from either contemporary or historical barriers that have added sort of layers of difficulty in regards to like their perception of illness, in regards to their perception of health and that kind of thing. And so there's no way that any of us can do this alone. Like it's absolutely wrong that one can actually, and it's particularly sort of a large function of being a medical oncologist is that none of the care we deliver can be safely done like between physician to patient without this sort of giant web and nexus of support. I like Hillary Clinton, whatever one may think of Hillary Clinton, has sort of popularized about it taking a village to raise a child. There's no doubt that whether you come from sort of a large urban community or a small village, it takes a village of support within one's home community and within one's sort of caring community to actually successfully support someone through their treatment of cancer.
Absolutely. And I think that this is probably a perfect spot to kind of wrap things up and maybe continue with just the takeaways that we're leaving this at the end of this video. So what I'm hearing from you and from our conversation is really understanding the factors in which a client lives, the context in which they live, and the factors that are going to impact their journey is really key to being able to move through the whatever cancer treatment you're going to offer. As well, ensuring that you're collaborating and reaching out with the resources that exist outside of us at Cancer Care Manitoba, so that we work as a team, because it will take multiple contributors in the healthcare system to ensure that we help folks move through that journey and reach their full health potential, which is essentially the goal of health equity.
I can only echo that. As an individual clinician, it is incredibly more gratifying to be connected with not only the patient but their community, to be reaching out to I frequently speak with different CCP nurses, with our colleagues throughout Manitoba, and as an individual physician, it makes my job a lot more gratifying and even a lot more successful, because even if the survival outcomes may not be superior, the journey and experience of care that our patients encounter is smoother, more complete, and more integrated. And I encourage the students that work with me to, before one talks about anything as far as intervention or treatment, to be getting a sense of what perspectives are, what framework people are seeing themselves in their world with, and what they'd be returning home to once they leave that clinic space.
That's great. Well, thank you so much for your time today. We'll do a formal handshake.
Okay.
And for all of those watching today, please remember, connect with us at the Underserved Populations Program, and we'll leave you some information. If you have more questions about health equity and ways that you can support your clients through their cancer journey.
Thank you.